Good afternoon. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy Education International. We are hosting this program today focusing on myelofibrosis, and with me today are doctors Brady Stein at Northwestern in Chicago and Dr. Linda Resar from Johns Hopkins. And we are going to try to cover a lot of ground today. I'm going to start with Dr. Resar, who will share what's going on in her lab and at Johns Hopkins. And then I'm going to ask both doctors to share their feelings and thoughts about the fact that ROPEG has been approved by the FDA. And then we have lots and lots of questions from all of you. So Dr. Resar, would you like to begin?
Of course, first, thank you so much, Anne, for this opportunity. It's an honor to be here with Dr. Stein, who is doing great work with our patients. How can I share my screen? I don't see the little screen. Oh, here we go. Sorry, there it was. Okay. Is it sharing? Can everyone see? Okay, great. So my laboratory actually studies really basic mechanisms that cause MPN and drive progression to myelofibrosis in an effort to better understand what happens at the level of our cells so that we can come up with better treatments. And so we have some very exciting results. I'm just going to share really briefly because I know you all have questions. But my laboratory studies a gene called high mobility group A, or HMGA, and we found that in patients with MPN, it becomes hyperactivated. And we found that, for example, I'm showing you some graphs from independent studies. The first is from our cohort at Hopkins, if some of our patients for whom we had the appropriate stem cells to look. But you see that in PV, shown here, the levels are higher than what's seen in normal blood stem cells. And as patients progress to MF and AML, it goes up higher and higher. And that gave us our first clue that this could be driving disease progression. And then the next set of slides, this is just independent patient samples that show the exact same thing. And believe it or not, we actually have mouse models where the mice develop overproduction of blood cells, just like our patients. I'm showing you their blood counts here. These are their platelet counts. Even their spleens get big. So it's really a beautiful model for PV and ET that progresses to myelofibrosis. And when you look in their marrows, you can see that also they get fibrosis. And on the bottom, these are our MPN mice. So they harbor the JAK mutation, which is one of the most common mutations we see in our patients. And when we cross them to a mouse that has just a half of dose of this gene, they do not develop myelofibrosis. So their spleens stay normal, and that's shown here on the bottom. Their bone marrow never gets fibrotic. And they also, you can see in this bone marrow aspirate on the left is a normal mouse we call wild type. The middle is a JAK mouse that has all kinds of fibrosis. And then on the right, it's indistinguishable from normal. And that's showing just half a dose of this gene. And so we've gotten together with a group at Mount Sinai in New York, thanks to Ron Hoffman. He has colleagues who are developing really exciting technology to destroy proteins. And we're hoping to destroy this protein or degrade it in patient cells. And I just wanted to give you a little, I won't go through this drawing because it's a little bit complicated, but these are drugs that target a protein causing MPN progression and then degrade it. And we're just really excited that we have this target and that we see really dramatic results in our mouse models. And we're hoping to be able to translate this to our patients so that we can prevent this process. And I know Anne said just one slide, so I went a little bit over, but I hope that was helpful. Oh, Anne, I don't hear you. I think you might be muted.
I was muted. Sorry about that. Can everyone see me? Because this screen has something on it. Who has to stop sharing? Linda, you need to stop sharing your screen.
Okay, so how do I stop sharing?
Sorry. down at the bottom.
Okay. Oh, there we go. Sorry, it's red. Mine's
There
at
you
the
go. Perfect.
Sorry, everyone.
Well, all I can say is that is fascinating. And the interesting thing is I spoke to Ron and you at the MPN Congress in New York a couple of weeks ago, and he mentioned this. And I mean, this is groundbreaking, really, very much so.
Excited.
So I'm very excited for our MPN community for sure. So as I mentioned, I want to get feedback first from Dr. Stein and then from Dr. Resar. We are elated every time a new drug is approved for our MPN patients. As you all know, we have 2 that have been on the market for a while, and now a 3rd that has been approved. And this is big news. And Dr. Stein, what would you like to share with us about this?
Sure.
Approval?
Yeah, thanks, Anne, again for having me on. It's good to see you, and it's really good to see you, Linda, as well. We know each other from Hopkins, so this is a great panel to participate on. No, we're all really excited. We've been waiting for a fair amount of time for this approval. I think we were anticipating the drug being approved last spring, so we've had a lot of really interested and excited patients waiting for the ability to start this medication. So, no, I think it's always good to have more and more options, right? I think the field has been stuck for a long time with minimal options, especially for ET and polycythemia vera. When we're talking about having 2 to 3 medications, and a lot of patients, those medications may not be suitable for. So more and more options is extremely important. And I think what is kind of exciting about this medication is, I think at least in the academic community, perhaps this is a paradigm shift, this medication. What we've always done is, for the most part, waited, right? We've done a lot of waiting until something happens for our lower risk patients and then maybe starting a medication, right? The reason we've done that is because we haven't always been satisfied with the options we've had. And in some respects, some of the drugs have been tested that way. Don't use them first, maybe use them second, wait until something happens. So what I think is interesting about ropeg interferon is this is an option for patients who certainly have had an insufficient response to another medication, but it's also been tested in patients who haven't been really previously treated. So it represents a first-line option for patients with polycythemia vera. So I think what we'll have to see is, does this shift our paradigm into earlier interventions? I think that's what a lot of people in the field are excited about.
I love that you brought that up, Brady, because that was discussed at this event also. When do you intervene? When do you start to treat MPN patients? And I think it's a great point, because we haven't had the best, we haven't had enough treatment options. There have not been enough. But Linda, what are your thoughts?
Yeah, so I would first echo all the excitement that Dr. Stein mentioned. And I'm, as you know, trained as a pediatrician, so all my patients are young. And so for every single patient that I see, if they're 10, 15, or 20 years old, I'd like them to live another 80 or 90 years. And so I'm always looking for therapies that we can start that will actually modify the disease and decrease the abnormal clones. And even in my patients who are asymptomatic, I typically start interferon. And as you all know, the current available therapy for interferon prior to ropeg was once a week. And kids in particular, teenagers, college students, the last thing they want to do is show up at some clinic once a week for an injection and blood count. So I think this will be game changing for my young patients. And, I'm really excited to try this and, to see how our patients are doing, because this particular treatment has the promise of actually decreasing the abnormal clones. And that is really wonderful. And now it's in a very accessible form. And so, we'll have to see how patients tolerate it and hopefully, usher in a new paradigm for treatment.
Yes, I agree. Can you, Brady, tell us the difference between ropegylated interferon versus pegylated interferon?
Yeah, sure. So I think the main take-home difference is the structure. So practically, there's a longer half-life for ropeg interferon, so that allows for less frequent administration. So initially, during the kind of startup phase, getting used to the medication, it'll be dosed every 2 weeks. But then after a certain period of time, once we're in a maintenance phase, the drug could be administered once per month. That's going to be a huge advantage to do an injection once per month that could potentially control your blood count. So the difference, whereas pegylated interferon typically is dosed once per week. So that's really the main difference, is less frequent administration.
Right. Okay. So moving right along, although this is very exciting news, and there are a couple of other drugs in the pipeline that are coming real close to commercialization. And you know, the three of us have been around in this field for a long time. I'm not a physician, obviously, but you know, it's been almost 17 years that I've been in the MPN space, and I have to say, it is unbelievably exciting to see what's happening in this field and in the way of possible treatment options. And so let me start with asking you, you know, you talked about progression, Linda, and this is a big question on our list of questions. And that is, you know, I know the Research Foundation, who we love dearly, is getting into some science and trying to figure out, you know, where are we going to go from here? And that is a question that we always ask our patients. What is your biggest fear? And much of the time, besides the psychosocial issues of finances and access, is progression. What's going to happen to me next? And so to Brady's point about, you know, possibly being able to have intervention earlier in the disease, even when there maybe aren't a lot of symptoms, but it's there. But also to the work that you're doing at Hopkins, what are your thoughts? What can you share with our patients that are concerned about progression? And in this case, these are MF patients, so progression to AML. Linda?
Oh, okay. Yeah. So we've been, you know, really interested in that question. And we've had an opportunity to actually look at the genes that are turned on in myelofibrosis and how that gene pattern changes when patients progress to AML. And we're finding some very interesting changes that potentially could be treated with therapy. And so, you know, the $1 million question is, what changes? Why does it change? And even more importantly, how can we prevent it from changing? And so with, you know, emerging technologies where it's much less expensive to take a patient sample just from peripheral blood and look at what genes are turned on now and how we can keep a certain pattern repressed or active. Like, for instance, one of the signals we saw when we looked at, you know, sequencing of our patient samples is that when patients have not yet progressed, their immune systems are still very active. They're actively looking for abnormal mutated cancer cells. And when the patients go on to develop leukemia, this immune signal is no longer present. And so, you know, I think one of the exciting areas will be, how can we keep the immune system active so that these cells are not allowed to progress and continue to mutate? And so I think that's a very exciting area. And as you know from the meeting in New York, there are lots of groups looking at that and looking to treat and prevent that from happening. And there's some very exciting data with interferon that patients who have been treated tend not to acquire more mutations, which tend to associate it with progression. And that suggests that their immune systems are staying more active than the patients who progress.
Okay, interesting. Brady, do you have anything to add to that?
In terms of progression, yeah, I mean, I think that you kind of brought it up, that these are the family of illnesses under the umbrella of MPN are all chronic illnesses. And I think that that's one of the hardest things for the patients to live with, is having a chronic illness and under the constant worry about when it will progress. You know, visit to visit, we have patients who are extreme, you know, when they come in, the blood pressure is really high and they're really nervous until the blood count comes back. And a lot of these patients have been even stable for 7 to 10 years, but it's still kind of that constant worry when you have a chronic illness, sort of waiting for the other shoe to drop, so to speak. Progression is on everyone's mind. It's on our mind. It's on the patient's mind. I think from the physician perspective, from the the scientists and the clinicians, we've always been wondering and worrying about how can we stop it? Who will progress at what rate, when, and what can we do? And I think that kind of goes back to the first point about we haven't had a lot of interventions that have been proven to delay progression. And so we've been using medications more selectively rather than generally, because the lack of options and the lack of proof that a lot of the medications we've had can really stop a disease in its tracks.
So with this new approval, let me ask this question. So let's say I'm a PV patient who's doing pretty well, doesn't really need a lot. Would you propose to me, would you say, perhaps you would be a candidate to start this interferon or, something else to halt or keep progression at bay? I'm just clarifying, is that what you're saying, kind of, that if I have ET or PV, that's possible that an earlier intervention with an interferon or something else could possibly prevent progression?
So I would say possible, but we have to be careful about proving.
Yeah.
There's educated speculation, but proof, there's not proof in terms of like the highest quality of proof would come from a randomized control trial. Those studies are virtually, they're extremely difficult in this field because we have a rare disease, we have a rare event, and the event takes a long time. And for us to get the answers we really want to critically evaluate a drug, we'd have to have clinical trials that have hundreds of patients in each arm that are followed for 10 to 15 years. So that's where proof would come. It's going to be hard to have proof. We have to rely on kind of educated speculation, hypothesis. So I try to be careful about saying it's proven to delay or modify the natural history, because there are patients who don't want to start medications, but if we tell them, hey, we have this medication that's proven to change, but they make a decision not to, I think they're left with a lot of guilt, either them or their family members. So I try to be careful with how we characterize what the medication can do. This medication, ropeg interferon, is approved for PV, so we can't really use it for ET or myelofibrosis. This is brand new, so we've got to play by the rules. We've got to stick by the books here. But I think that it sort of introduces this question about what we should do. Should we wait until a patient becomes high risk or intervene early? I mean, that's kind of the paradigm shift. And, there are other places, MPN physicians in other countries where this paradigm doesn't exist, and I'm not sure that the idea of a low risk PV patient, that concept, I'm not sure if that exists in France or Austria or, Denmark, where some of the strongest proponents of interferon start early when you have a diagnosis, but not based on a risk classification.
Right. Okay. So I'm going to shift gears a little bit here. This is from a patient. I have MF and have been on Jakafi and aspirin for 12 months. Blood levels are now stable after 10 years, but I have gained 10 pounds, is that? In 12 months with no other reason for the weight gain. And it makes me not want to take it anymore. I'm sorry, I'm laughing, but because that is not fair. But Linda, we do hear from patients that say, I've gained a lot of weight, taking not just that drug, but other drugs, for their MF. Is that typical? Is that something you see often?
So I have to say, since I take care of younger patients, it's quite rare to have a younger patient with MF. I do have one patient who is on Jakafi, and he has an extraordinary course. He was diagnosed with PV at age 18 when his parents picked him up from college, and he was yellow. So he'd had a Budd-Chiari, he had a thrombosis, and actually had to get a liver transplant. He's doing great. I mean, he loves to scuba dive and feels really good. We had initially treated him with interferon right after the liver transplant, and that led to some inflammation in the liver. And since then, he's gone to Jakafi. And I know he has not gained weight, but he's also, at an age like, he's now in his 20s, almost 30. And so it might be very different for somebody who's a bit older and they're experiencing other life changes. So I cannot say that I've seen that, but certainly those kinds of side effects are bothersome. And, you have to balance weight gain, which also brings along quality of life changes from, the benefit of the medication.
Yeah, I could say, unfortunately, I've seen this very commonly. So there's a fair amount of weight gain, 10 to 15 pounds. I sort of counsel about that. I don't think it's always counseled upon it because it's not always on the radar. I think people think more about blood count drop, skin cancer risk, cholesterol change, and risk of infections. But weight gain, I've seen it really commonly in PV and in myelofibrosis. So 10 to 15 pounds is, and these are patients who are aware and also, not doing everything they can. There are two groups. There are some that lifestyle doesn't change and the weight gain still comes. There are other patients who are feeling terrible, right? Let's say a patient had myelofibrosis and a lot of inflammation and weight loss and having trouble keeping weight on. And so kind of adopting a lot of behaviors, high calorie foods and eating a lot of junk to feel better, but to try to keep weight on. And then if you have that and you bring on this medication, you can have weight gain for two reasons. But I can also share that it's happened in patients who really don't have a poor diet or who are still exercising, who are doing everything they can. So something to be aware of. I haven't stopped the medication because of weight gain because we have to look at what else it's doing. And if it's overall, if the net effect is overall positive and it's really helping a lot of the other symptoms and signs of the illness, it's something we want to try to work through rather than stop.
Yeah, and I think you're absolutely right. If I'm not feeling great, I'm not moving much, sometimes I'm not moving, I'm eating more, but I'm not walking or exercising. And, we see everything across the board, but I have talked to patients over the years that said, oh my God, I gained so much weight, and so I think, it's an important question. And I like that you mentioned it's something that isn't talked about, but should be, because it does happen. Why do some physicians choose interferon as opposed to hydroxyurea? And someone, for example, this person is 43 years old and was diagnosed with ET and is a CALR mutation. Linda?
Yeah, so I can say, and again, this is from the lens of caring for young patients as a pediatrician. Hydroxyurea can benefit patients in lower counts and make people feel better. It also, because it interferes with how cells divide and replicate their DNA, it can cause additional mutations. And so as a pediatrician, that's a big worry for us. If somebody is, 70 or 80 years old and are planning to be treated with a drug like hydroxyurea for 20 or 30 years, it's less of a concern. If you're 15 or 20 and we're planning to treat you with something for 80 years, it's more of a concern. So we tend not to use that in our young patients. And we tend to try to use interferon in our young patients because it tends to be well tolerated. Now, there is some evidence, and again, as Dr. Stein mentioned, this is new. We'll have to follow patients for decades to know the answers to all of our questions in a very evidence-based fashion. But there's some evidence to suggest that CALR mutations may decrease less than JAK mutations in the setting of interferon. And again, it's new. We need to look at that in more patients, but that's another reason why some may be less enthusiastic about starting interferon in somebody with a CALR mutation.
Brady?
Yeah, I think it also interferon is very polarizing, has a stigma, right? So, a lot of physicians will hear the term interferon and not want anything to do with it. But they might be thinking about recombinant interferon, the oldest generation, and they might be thinking about it in another condition. It was most commonly used in, for example, like hepatitis C at much higher doses. So it has a stigma in terms of side effects. Not to say that the newer generations don't have side effects, but that class of medication we know has adverse events like any medication. And I think it has a stigma for sure. So you won't see too much interferon administered in a community practice setting. Interferons, I think you're going to see the recommendations coming from the academic communities, right? So for a patient who needs a medication to lower the counts, they're not seeing in an academic center. I'm not saying one center is better than the other, but just practice patterns, 90% of the time or 95% of the time, hydroxyurea is going to be favored. So interferon has a stigma. It's also not so easy. When we prescribe it, almost always it gets denied the first time around. Every new year when we have to reapply for it, denied. We've got to go through one appeal, then the next, and then an external appeal. So a lot of physician offices really don't want to deal with that kind of struggle. So, in terms of stigma from its side effects, and then it's a lot easier to prescribe hydroxyurea. So there's a lot that kind of goes into why you see much more hydroxyurea being given across the board than interferon.
Mm-hmm. And we do, there's so much more we could discuss about this, and at some point we will, but I do think it's interesting. I remember, just over the years hearing from different physicians, and researchers, and just as you said, there are really several schools of thought. I don't prescribe anything. I do prescribe interferon, and I do prescribe HU, and it just goes all over the board. So, and I do have to say, I think it's been an incredible journey for me, and very interesting how educated our patients are, and I hope we play a role in that. But I love hearing from all of you, because it's important to hear where they're coming from as well. We would be remiss if we didn't ask some questions about the vaccines for COVID. We are still in a pandemic. I have to laugh when I hear people say, well, when we were going through the pandemic, and I think, my God, Michigan is at this high peak right now, and New England, and people are still getting the virus, and there's still people dying from the virus. We all have been fully vaccinated, and I got my booster shot, and I'm very happy I did. Can we talk about Jakafi? And there was something about it had shown to interfere with the vaccines. I'm not sure. I heard a little bit about this. Also, will data be out for MPN patients receiving the third shot and antibodies being increased? Would either of you like to speak to this? Brady, I guess I'll start with you.
Yeah, I think that's the topic of the day. We've gone through different waves of illness, and we're still in the midst of illness, but I think a lot of the questions right now are about vaccination. And so, I think as physicians, the answer is almost always the same. It's really like, we're kind of like almost robotic in our responses, but we believe it, that the risk of the virus definitely outweighs the risk of the vaccination. So we're really trying to encourage our patients to get vaccinated. I do think that my MPN patient group has been very highly vaccinated, very, very motivated. I think, having chronic illness, and I think a lot of our patients, like you said, are extremely well-read and know how to look at medical literature quite at a high level. I think that could account for it. But in terms of antibody responses, that's a tricky situation. There are some reports, whenever some of these reports come out, we get messages the next morning, right? I think one of the first ones had a very general title, like blood cancer patients may not respond to the vaccine. Blood cancer is a big group. You've got acute and chronic blood cancers, you've got myeloid blood cancers, lymphoid blood cancers. You've got groups of patients that, because of their treatment or their disease, don't make antibodies well. So when you look at the details of some of those papers, most of those patients including in the studies are not patients with MPNs. The studies that include patients with MPNs are really, really, really small. You know, I looked at it this summer for a presentation, and we're talking about on the order of 20 or 30 patients, and some of the antibody responses were after a single dose, not a second dose. So it's hard to make any kind of conclusion. I would say that yes, I mean, ruxolitinib suppresses the immune system, so to me it makes sense that there's a possibility that the vaccine response may not be as robust. So when I'm kind of counseling patients, I generally say that I don't think hydroxyurea suppresses vaccine response. I don't think ET or PV by itself suppresses the immune response to a significant degree. And within myelofibrosis, that's a pretty heterogeneous group. I think that those patients may be more at risk for a low vaccine response, especially patients on ruxolitinib. But that shouldn't stop you from getting the vaccine, but it should sort of tell you that even if you do get the vaccine, you should still be careful. We all still need to be careful. All of us who are vaccinated we're not out of this. So we can't just act like we used to act 2 years ago.
Right. Linda, do you have anything to add to that?
Just a little bit, you know, and as Dr. Stein mentioned, these studies are small, but there were a number of studies that came out of Italy first, since they were hit so hard. And again, that population tends to be an older population, but based on the data there, which included older patients, some with advanced disease, they tended to do worse with COVID than people who didn't have advanced MPN. And so just as Dr. Stein and as you have been mentioning, that leads us to strongly recommend getting immunized. I think that's important, and particularly for our older patients with MPN, because they have other risks for having more severe disease. And then the therapy has been interesting because, you know, with Rituxan, which is a JAK-STAT inhibitor, the virus itself activates JAK-STAT signaling, and there have even been some small clinical trials using these inhibitors for the infection. Now, the data, because these studies are small and there's so many factors that make people sick with COVID, they haven't been clear cut, but there's even evidence that, you know, Rituxan could ameliorate some of the activation caused by the virus. And then the other concern for our patients on interferon was, well, since interferon is activated by viral infection, will this be a problem? And all of our patients who've been on interferon and from multiple centers have tended to do pretty well. And in fact, there's even a little bit of data to suggest that interferon may boost the antibody response. So, you know, just as Dr. Stein said, we're strongly in favor of getting vaccinated. And I think especially older patients should definitely get vaccinated. They're offered the third vaccine now, as most adults are. And so that's a population where we feel very strongly in terms of vaccination, but all of our patients. And, you know, just like you, we've all been immunized. And
okay. Are there studies that support or dispute the long-term use of hydroxyurea and a link to peripheral neuropathy? Brady?
You know, I actually I don't know too much about the association between hydroxyurea and peripheral neuropathy. So I'm not sure I'm not aware of how strong that association is. I mean, with hydroxyurea, the counseling we tend to give is one, suppression of blood counts. That's often intended, but we want to make sure there's not undue suppression. We counsel about mouth sores. We counsel about ankle ulcers. We always counsel about that one because that often is a deal breaker for hydroxyurea. If you have an ankle ulcer, that often means you have to discontinue. There is a risk for skin cancer, so we want our patients to get once a year skin checks. And then there's some rare things that we've all had patients experience really rare side effects. Things like fever, things like, you know, liver function test abnormalities. They're rare, but they can happen, and sometimes they don't get better until the drug is stopped. The big one, the controversial one, is the association between hydroxyurea and leukemia. And I think it's controversial. It's been controversial for the whole time that hydroxyurea has ever been used. But it's hard to say that over the last 20 years that there's hard statistical proof that it's a drug that definitely increases the risk of leukemia beyond the spontaneous risk of the disease. But just like I mentioned about clinical trials before, you can't find studies that 100% disprove because of the same issues with study design. So it's why we don't give it to everybody. We use it selectively, and it's why we don't generally use it for younger patients because of that concern, as Dr. Resar suggested.
So I mean, just from my experience, a lot of patients talk about neuropathy in their feet, in their, we hear it a lot. And so is it possible that it's just part of the disease, that it's just part of, the MPN?
Yeah, it's possible. I can see it with long-term pegylated interferon use. Definitely have had patients develop neuropathy, you're right? I mean, it could be in part a vascular issue. I think it comes up on symptom assessment. Numbness and tingling is one of the key symptoms we ask about in clinic. There's also other conditions associated. There are other age-related or unrelated conditions that can cause neuropathy too. So, when something comes up, because this disease is kind of mysterious to a lot of people, these diseases always get blamed first for everything, right? And so if you have a symptom and you see a primary care doctor, they might blame this disease first, and that might be right, to think about the disease and its treatment to see if it can be causing a side effect. But patients are allowed to have other things. Sometimes they have other things. And so we kind of look at it and say, I don't see it as likely, or I do see it as likely. And then we sort of try to triage the symptom and then refer back or not to the primary care doctor.
Does disease duration impact the likelihood of transformation to myelofibrosis? If someone has been diagnosed with ET at the age of 21, and is the bone marrow likely to fail or mutate by the time they're 80? Linda?
Yeah, I can speak to that because as Brady knows, we have this huge database at Hopkins, and we followed patients, over 600. And for most of those patients, we know whether they had a JAK or CALR or MPL mutation. And in many of these patients, we have enough follow-up to know when they transform, because I think some of the patients were diagnosed, in the 1900s, mid-1900s. And at least when we put this data together, and it's not yet published, we presented it at ASH in the past. But when we look at the young patients, their duration of disease prior to progression is much longer than a patient who progresses who is diagnosed later. So which means, like, if you were diagnosed at 20, the duration prior to progression is longer. But at least in our database, and again, it's small because this has been infrequently diagnosed in younger patients, they did tend to, at the age of progression, was younger than somebody who was diagnosed older. Does that make sense?
Mm-hmm.
And as you know, it's some very exciting recent data is suggesting that even for patients who are diagnosed in their 40s or 50s, when you try to evolutionarily trace the onset of the acquisition of the JAK clone, there is really, I think, exciting and compelling data suggesting that in some patients, it starts in utero. So that sort of just changes the paradigm of how we think about this disease. Some patients are acquiring it much earlier in life than we appreciated, and that's becoming clear through better sequencing technology and the ability to trace back clones. So as we understand it now, that's what I can tell you based on our current data, but that's totally subject to change as we are able to detect these mutations at a much lower rate.
Mm-hmm. Brady, do you have anything to add to that?
No, I mean, I agree. I think that the challenge for the younger patients is that there's more time to evolve, right? So that's kind of what I share with our younger patients. Let's say that it could take, let's say, 35 years for this to progress. Well, if you're diagnosed at 65, you may not experience it, but if you're diagnosed at 25, you have so many years for this to happen. So I do think that that's one of the particular challenges of having a diagnosis at a young age. But what I also share with patients is that with the landscape, who knows how we're going to be treating this in 3 years to 5 years. I mean, so there's a long time for the disease to progress, but there's a long time for, new scientific developments, new medications, new research. So that's also how we kind of share that type of information.
Yeah. This is a good question. Does being on Jakafi increase the likelihood of having shingles with my MF? Brady?
Yes, it does. So, I mean, infections are a risk with Jakafi. So what I try to do before a new start of Jakafi or ruxolitinib is try to update all vaccinations, right? And so make sure, of course, get your flu shot. Try to make sure you have your COVID-19 vaccination and your booster. Try to, if we can, we try to time those vaccinations first, make sure you're up to date on your pneumonia shot and vaccinate against shingles. So there's the Shingrix vaccine, which is inactive. So we like patients to get at least one dose before they start on Jakafi, because shingles is definitely, it's one of the more common infections we see with ruxolitinib.
And is it possible to be misdiagnosed with AML, but you really have MF, Linda?
Well, so many of us think of it as a continuum, and some people in the MPN field describe a blast crisis, which can encompass MF because there tend to be increased circulating blasts. And when you look at the marrow, there is an expansion in blasts. AML tends to be a more extreme, version of this blast crisis. So it can be a continuum, although it doesn't mean that every patient with MF is definitely going to progress to AML. So, I think there's a lot that we still have to learn about which sorts of genetic lesions indicate one versus the other.
Brady, have you seen that? Has that happened?
Have I seen patients being misdiagnosed as AML but having MF, or having MF being misdiagnosed as MF and having AML? Not too often. I think it's well said by Dr. Resar that it can exist on a continuum. I can't say AML, unfortunately, when it rears itself and makes itself fairly obvious. And so, one of the ways we know or worry about it is in MF patients, if the peripheral blast count starts to rise above 20%, that's a diagnosis of AML, or in the bone marrow, if the peripheral blast count or the bone marrow blast count is above 20%, that's acute myeloid leukemia. So unfortunately, it kind of rears itself, reveals itself.
What are the important markers in my blood that show potential signs of progression? And would a patient notice the differences? Linda?
Well, to follow up and maybe re-echo what Dr. Stein said, as physicians, we follow the blood counts. And so if there's a change in blood counts and, the blasts are, when they increase to a certain level, either in the peripheral blood or the marrow, that indicates transformation, which is the process we call when blood cells that are more normal transform to a more malignant or leukemic phenotype. Many times when patients do progress, they feel ill. So, it can be noticed by feeling poorly. Sometimes you can get a much bigger spleen, but we know some of our MF patients have big spleens too. And sometimes there can be, worsening in anemia. So somebody may feel less energetic or become more, pale. But again, those can be signs of just MF alone.
So there are several questions here. I love these questions because they're very thoughtful. My husband has MF and dementia. Is there any relationship between the two? For example, is his blood, to his brain keeping him from getting enough oxygen, causing his dementia? Brady?
That's a good question. I don't know of any very obvious link between the two, although there's different types of illnesses that result in memory loss or neurocognitive types of disorders. So I don't know of a clear link between the two, but there are vascular type dementias, and these diseases can be vascular. So a series of blood clotting abnormalities could be one link. So a patient having recurrent stroke and a vascular dementia, that could be a possible link. But otherwise, I'm not yet sure of a very clear link.
Linda, did you want to add anything to that?
No, I would agree with that.
Does having a stem cell transplant interfere with other procedures I may need, such as knee replacement or other things that are required later, Brady?
Yes, not forever, but when if the patient goes on to have a stem cell transplant, that will dominate the clinical picture and the clinical course for usually up to a year after the procedure. So things that would be considered elective, things that are important but considered elective, like a joint replacement, that would definitely be put off, because the priority is to recover from stem cell transplant, to restore the new immune system, and to try to avoid things that could potentially result in setbacks or could be hard to heal from. So not saying that if a patient had stem cell, they could never have a joint replacement, but you definitely want to delay that until the stem cell transplant doctor thinks that you're ready to go ahead with something like that.
And at what point is a person no longer a candidate for a stem cell transplant? Either of you, Brady, do you want to start?
Well, that's a good, it sort of depends. I mean, this is going to be a vague answer. Timing, candidacy, timing, these are the biggest challenges. And so what we first think of is often age, right? But age is not always a contraindication to transplant. But there are certain ages where above which, no matter how healthy you are, the transplanter probably won't go forward. So on the upwards of 70 or above, I think that the transplant doctors and the hematologists are going to be reluctant. So age can present a contraindication to transplant, especially above 70, 71, 72, 73. But there are patients who are 53 who have very limiting health conditions that might make the transplant too risky. So age is one factor, but the rest of your medical health is another big factor. I think it's important to have, you have to have a dedicated care team. Having an available caretaker, no one can do this alone, I think is another important consideration. So, there's a whole, we're thinking about a lot of different things when we're referring a patient for a transplant, and the transplant team is looking very comprehensively at not just your medical health, but other determinants to make sure that you're positioned for success.
As a new patient, how do I find the right doctor, the right MPN specialist? We get calls about this all the time. Does it matter how many current MPN patients they are seeing or have seen? I could anecdotally answer that, but Dr. Resar, what would you suggest?
Well, so actually two answers. So first off, at larger academic centers, as where Dr. Stein and I work, we tend to see more patients with rare diseases because they tend to travel. However, I have, like, one of my patients right now lives in Minnesota. And so she has a local doctor and may come to see me once a year, or we may just do video visits if there's a pandemic ongoing. And so we're always more than happy to, consult with local doctors to help manage the care of a patient who might be complicated or have a disease that the other physician may not see many patients with. So I think in general, patients, do well to see somebody who sees a lot of these patients, who's experienced. For younger patients, you may want somebody who, if they're a young child, a pediatric viewpoint would be helpful. But I also, for my young patients, consult with my adult colleagues who see more of these patients because it's more common in older patients. And there are a lot of great centers throughout our country where people specialize and focus on MPN. And there are some patients who may not be able to get to those centers, and we can help as well manage and help provide guidelines.
Brady, do you have anything to add to that?
No, I think that's well said. Telemedicine certainly changes things. The only silver lining of the pandemic was telemedicine got ushered in 24 hours, where people have been debating how to use it for years. In 24 hours, it was started up and it's sustained. So, so that could make the world a little smaller in terms of seeking out like an expert opinion, but at the same time, you can't manage someone from really far away. You can't have a patient who lives halfway across the country and you're their doctor, because if something comes up, they have to have a go-to. So you got to have a team, and the team is someone who is local And maybe there's a disease expert also part of that team, and then you can kind of share in the care of that patient. And I also, kind of share with our patients, don't disparage your local doctor. A lot of us wouldn't survive a day in those practices. They're seeing everything under the sun, and they're keeping up extraordinarily well with rare diseases or common diseases. And these fields, hematology, oncology, are changing at unbelievably rapid paces. So I tell the patients, like, if I were in one of their clinics, I'd be hiding under the desk back after the first, 3 hours. So we complement one another. We get to see the really rare things and sort of hyper focus on the rare, where they have experience seeing the very general. So working as a team, I think, makes sense.
And as Linda suggested, first of all, the physicians and clinicians and researchers in the MPN field that I know, which are many, are amazingly wonderful people that will consult with your local physician. So if you have a local hematologist somewhere that really doesn't see a lot of MPN patients, maybe you're the only one, maybe you're one of 5, but that physician is open to consulting with a number of different MPN specialists. I don't know one of you that hasn't said, of course, they can call me, we can set up a consultation. And so, we can direct you in the city that you live in, whoever wrote that. We do that quite often, where we'll say, well, there is somebody in this city that could help. And also taking information to your physician, to the person that is treating you for your MPN. There's lots of literature out there, these programs, other programs that are really educational and help. And hopefully your physician is open to hearing what's going on in this climate and in this world, because that is very useful. But as Brady said too, it takes a team. Everybody should know what's going on with you. Any specialist that you see should know what's going on with you, and work as a team. So let's see what I have here. This comes up all the time. I'm sure the two of you hear this often. What can a patient do for bone pain, to relieve their bone pain? Brady?
This is a tricky one. So when we ask, when we talk to the patient about bone pain, we want to try to distinguish, do we think it's coming from the MPN or something else, right? And so I tend to think about bone pain from the MPN if it's involving the long bones. So like your shins, your thighs, maybe the upper arms. So kind of a burning ache, whereas joint pains might not always be related. So joint pains, the first thing I would think about is something like osteoarthritis, kind of wear and tear. So the first thing is to try to figure out, do we feel confident where that bone pain is coming from? Because the treatments are going to be very, very different. For patients who have bone pain related to their myeloproliferative neoplasm, usually like an anti-inflammatory strategy is probably the way to go. And so those are patients that I might think about a JAK inhibitor.
Okay, Linda, do the younger patients you see have experienced that as well?
Well, one of the conflicting symptoms or one of the overlapping symptoms we get from our young patients are growing pains, which actually do occur during usually pre-adolescence, when they're their long bones are growing more than any other time in their life. And that can sound just like what Brady was describing. And younger patients with MPN tend to have lower allele burden. So if somebody were at a growth spurt, I would probably attribute it more to their growing, and just kind of general well-being activities that help many different kinds of bone pain, like growing pains or osteoarthritis, is to try to remain active and do gentle exercise. And so I would recommend that for young patients who might have bone pain from something other than MPN, and to older patients who might have MPN and osteoarthritis. Being able to stay active and do things like walking is very good for bone health.
And are there any new statistics? I think we may see papers now and then about lifespan for patients, with PV, MF, or AML. Are there any new statistics out there in the MPN world, Brady?
I'm not sure that there's anything very new in the last couple of years. that I could quote. I think that what I would say is that it's a hard question to answer because it's so heterogeneous. I mean, we're usually talking about measuring in decades and decades and decades. So, but there's huge ranges within that. And that's because within each of these diseases, ET, PV, and myelofibrosis, each of these diseases is so heterogeneous, right? Low risk, high risk, different ages, different comorbid illnesses, different mutations. Within those mutations, different burdens of the mutations. So I think it's very, very heterogeneous.
Mhm. I would agree. Linda, do you have anything to add to that?
The only other thing I would add is with the new data suggesting that these mutations were acquired much younger than we appreciate, probably the survival is much longer than we appreciate, because you imagine if somebody got the lesion in utero, that's a long, long time, hopefully.
And I would add just, my uneducated opinion here is, that it also, I mean, there's no question that it can happen to anybody, that it gets worse or that some people stay, stay the same without ever taking anything, but also the management and of their chronic illness and lifestyle, lifestyle and management. I mean, it does seem to, because we've had people that have gone through horrible situations that came out of it somehow, but they seem to have a pretty good lifestyle in terms of taking care of themselves emotionally, physically, those things. And we try to address those, but as Brady said, it's a you just don't know. But it's better to err on the risk of taking better care of oneself. Is there a number or a time when a bone marrow biopsy is necessary? And what is, if the levels of their blood work is good to normal, do they have to have a bone marrow biopsy once a year, or is it usually when there's a change in their disease? Brady?
I think this question comes up
All the time.
every single webinar or meeting for the last 12 years I've had this. So
Yeah.
that's why I chuckled a little bit, because it's an important question, but it comes up all the time. Bone marrows are done for diagnosis. And so, for myelofibrosis, you can't make a diagnosis without it. For ET, it's used to distinguish ET from early myelofibrosis. PV is usually the most obvious that you can make without a bone marrow, but sometimes it's indicated for prognosis. So there's the diagnostic bone marrow, and then there's a bone marrow if we suspect something's changing. We don't do them just to do them. We don't do them yearly if everything is the same. We do it if we think that there's action to be taken. If we think that there's a possible progression of your illness and we need to change what we're doing, that becomes the time to repeat it.
Linda, do you have anything to add to that?
Yeah, I would echo that. And in terms of younger patients too, for example, if we saw a younger patient with a CALR mutation who had elevated platelets, but otherwise counts were completely consistent with the diagnosis, we may not necessarily do a marrow unless things changed or unless we were concerned about fibrosis. And same with PV, we may not do that at diagnosis. And that's what Dr. Stein said as well. But if counts change and we're concerned about there being progression, we might. And then the other thing that didn't get mentioned that's coming into play now with following patients, getting genomic diagnosis of their blood cells and stem cells is becoming much more common and much less expensive. So if we have a patient who has a JAK mutation and then maybe 4 or 5 years later, we know has many other mutations which are high risk for progressing or which could be associated with myelodysplastic syndrome, we might get a marrow to see if there is evidence for myelodysplasia. And that's relatively new because we weren't always looking at other mutations in one's blood cells until really the last few years.
Right. That's very interesting. So does having an MPN affect eyes or vision? And personal experience, a very dear friend who has polycythemia vera was having serious issues with one of her eyes and never put the two together. And I just happened to say to her, please let your eye doctor know what polycythemia vera is and have him consult with your MPN doc. Brady, can you address this? Like, I'm sure you've seen some patients with some.
Yeah, definitely. I mean, that sometimes that happens before an official diagnosis is made, or patients might have visual, ocular migraines or floaters or different spots in their different acute visual complaints. And sometimes they've seen a lot of different doctors before a blood count's done, and sometimes the blood count is finally done and the platelet count is very high, or the hemoglobin hematocrit's high. So sometimes these are presenting symptoms of the illness. These are also symptoms that we kind of track. Let's say that we're watching a patient and we're trying to get a sense if they're having symptoms from an illness. We usually ask about, are they having any acute or sudden visual complaints? So it's another kind of form of symptom monitoring.
And so would you recommend that if they do see an eye doctor or ophthalmologist, that there's consultation between the MPN doc and that physician?
Yeah, I think it's a good idea.
Yeah. And I think a person that heard us talking about including, they're going to see an MPN specialist and possibly having a call with an MPN specialist while they're with their current physician. And is that awkward, and how do you do that? I think a physician that doesn't see a lot of MPN patients would be open, I would hope, to having a consultation with an MPN specialist. I think, this happens quite often in any cancer. I've experienced it, other people I've known have experienced it, where you call somebody else in to have a discussion about it, someone that specializes in that field. If there is a problem, then I would say there might be a little bit of a problem with the physician you have. I hate to say it like that, but there are physicians. I would say the physician should be open to helping you and getting the answers and embracing the opportunity to talk with a specialist. Have either of you experienced this, where there's a problem with somebody's doc, consulting with you?
No, I usually have people say, please tell me what to do, what tests to get, where I should keep the hemoglobins, how to manage. Usually I've been lucky.
Brady?
Agree. Yeah. I mean, more people, it's much more the exception that you find friction with someone's doctor. We all want help. We want to work as a team. And so much more often than not, it's the same as Dr. Resar, that the physicians want help. These are rare situations, and they want a team member who sees a lot more of this than them.
Right. This question is something that, we know, I mean, I'm assuming you'll both speak to this. Are there treatments that shrink the spleen, Brady?
Yeah, there certainly are treatments that shrink the spleen. The class that probably does it most effectively would be the JAK inhibitor class. So the approved drug is ruxolitinib or Jakafi, and then the other approved drug is called fedratinib or Inrebic. Those are the two medications that shrink the spleen. Hydroxyurea to some degree can. Interferon, usually better with count control, not a class of medications that you'd see dramatic shrinkage of the spleen. And
does primary myelofibrosis lead to liver enzymes going all over the map? Their doctor tried to go in for a biopsy, but was unable to do so. Linda or Brady, either one of you?
What kind of biopsy did the doctor try to get? Liver or bone?
I'm assuming liver, but I could be wrong here. I'm not sure. Liver, I guess. Yeah.
So the one time where a liver biopsy can be hampered by a concurrent MPN is if there's a Budd-Chiari syndrome or a thrombosis. And that actually happened to my young patient before I saw him. He came in, as I mentioned, with yellowness or jaundice. And so a liver biopsy transjugular was attempted. And if there's a clot, that could be impossible. With the other thing, I wondered if the patient was asking about a bone marrow biopsy, because with fibrosis, aspirates can be really difficult to get from the marrow. So both of those can be associated with MPN.
Brady, do you have anything to add to that?
I agree. I think that with myeloproliferative neoplasms, particularly myelofibrosis, the liver can get enlarged. Sometimes that's due to what we call extramedullary hematopoiesis. So bone marrow cells kind of migrate from the bone marrow and set up shop in new locations like the spleen and sometimes the liver. So that could be one explanation for the liver enlarging, or sometimes there are changes in the on a CT scan or an ultrasound, the appearance. Clotting either of the hepatic vein we call blood Chiari or the portal vein can affect liver function. And then sometimes patients who have a really, really large spleen and there's a lot of blood volume, that can create situations of what we call portal hypertension, increased blood flow and pressure in the abdominal vasculature. So when there's liver abnormalities, I kind of think along those three lines, and then you think along, I guess, a medication could be causing liver irritation or something unrelated.
So we have time for one more question. We're a little over our time in terms of as we bring our partners in to give us updates on their clinical trials. But I wanted to ask, there was lots of discussion about this at different meetings we've hosted, and that is the pros and cons of telemedicine, and especially with MPN patients, because so much can change over the course of several months, and yet others may stay the same and everything's fine and just goes along. So what would you say are the pros and cons to your in-person meetings versus telemedicine, the meetings online with your patients, especially, during the lockdown? I'd say we're still in the pandemic, but Brady, Dr. Stein, can you speak to that? What did you find?
Yeah, I think there's pros and, like you said, there's pros and cons. I think the two have to complement each other. I think the telemedicine is great for someone you've met, where it's a routine visit and things are going well and there's not a new symptom to evaluate, a significant change in the blood count or a significant change in the physical examination. You just need to connect, discuss the routine, and if the plan isn't changing, perfect, right? We have patients who are driving forever. Well, you could live 12 miles outside of Chicago and it could take you an hour and a half. So it could be really frustrating. And, for a routine visit where not much is going on, that's perfect. If there's a new symptom, a change in treatment that's probably going to have to be planned, or a new physical exam finding, you can't measure the spleen on telemedicine. You have to do that in person. Those visits are accomplished best in person. I think it's hard to connect well in telemedicine, right? You connect in person, but telemedicine can be very brief, informal, and sometimes the engagement is different, right? It can be a small part of a patient's, they might be doing a million other things and they're squeezing in 5 or 7 minutes. So I think there's a time and a place for sure. It's here to stay, but you've got to complement your telemedicines with your in-person. I
agree wholeheartedly. Been there. Dr. Resar.
Yes, I would completely agree. The one time when I was felt very fortunate that we could do it was in the midst of the pandemic. If somebody's doing really well, the last thing you really want them to do is drive and come into a hospital and get exposed to patients. So then I think it was particularly reassuring, but that was, of course, with patients who were stable, where there wasn't anything new going on, in which case an exam, an in-person visit would be better.
So at this juncture, I would like to say thank you to both of you. You're welcome to stay and hear from the other guests here today, giving their brief updates on their clinical trials and what's going on in their world. But we feel that it's very important to hear from them. They not only support us, which we could not do our work without them, but also this is where our patients are learning about these trials and learning about what's coming down the pipeline and offering some hope. But I do want to thank you both so very much. I know how busy you are and your schedules are so busy, and we appreciate you very much. And I hope to see you soon. For the patients that are still on, we will have many more of these programs. And we thank you for joining us, and stay on with us so you can hear these updates. But thank you both very, very much. I appreciate it.
Good seeing you again. Thank you.
Good to see you.
Good to see you both.
Okay, take care.
Yep, you too. And so moving right along, we have many, many organizational partners as well as industry partners. And the MPN Research Foundation is a big one and near and dear to my heart. They are like our sisters. And we also have a lot of organizational partners, the PAN Foundation, which helps to provide funding for and access to your medicine if you can't afford it. Lots of different groups you can see on our website and other places in our website. And also the LLS, they are one of our dear partners, and I've been bringing Amy Lane. Hi, Amy. I wanted her to share because we offer lots of educational programs, educational pieces, materials. We offer advocacy. We do a lot of advocacy work on behalf of the MPN community. And so we want to engage and bring to you some of the groups that offer other things that we do not. And sometimes there's an overlap, but the LLS has just been wonderful. And I'd like Amy Lane to share with you some of the things they offer that we do not. Thank you, Amy, for being here.
Oh, sure. Thank you, Anne, for inviting me. It's always good to see you. I'm just going to share my screen. Okay. Can you see my screen okay?
Yes, except there's nothing there.
There's nothing there. Oh, no.
Just your name.
Oh, my goodness. Okay. Let's see. Looks like I'm frozen. So let's stop sharing. My entire screen just froze.
Would you like to just speak to that? Well, the way you are, so for the sake of time.
Yeah.
I see you. Hi.
Yeah, that sounds good. Okay,
Oh, there
sure.
it is. There it
Good?
is.
Okay, lovely. And you just see the slide, correct? Okay, great. All right. So my name again is Amy Lane, and I am an information specialist. There's about 15 of us, and we're located all over the country. So we're able to provide assistance from 9 a.m. to 9 p.m. Eastern Time, Monday through Friday. And we help folks by phone, by email, online chats, which is nice because we're able to also help folks internationally and share some of our resources with them. So as you can see on the slide, we offer a lot of resources from financial to educational to support programs. I'll just highlight them very briefly, but I just encourage you to give us a call. We'd love to meet you and talk with you, and our number there is at the bottom of the screen in yellow. So regarding our financial programs, we do have a number of them that you'll see here. We have a travel fund. It's $500, and that helps cover gas and tolls and parking and lodging and related expenses. We also have a patient aid grant, and that helps with really any type of expense. We also have an urgent need fund to help with non-medical expenses, and then also a copay program, and that helps with insurance premiums as well as medications. And we just expanded it a little bit further to include blood work and imaging and more. And we were able to even increase the income cap from 500% to 600%, which was very, very exciting. So we recently received approval to start an MPN fund. So we're just looking for some money to open that. So that should be coming shortly. And then we also have a nice list of organizations on our website, and those are organized by need. And then we also have educational materials, webcasts, podcasts, just to keep you up to date on the latest treatments and what's in the pipeline. We have blood cancer conferences. They're still virtual, but we're hoping, as soon as it's safe, that we'll be able to return again to having them in person. And then we also have our up-to-date COVID-19 information. And then lastly, many support services. As information specialists, we have kind of beefed up our Spanish-speaking specialists. So now we have a significant number of Spanish speakers, and then we also have access to 170 other languages through translators. And we've heard from about 95 different countries, which has been great. So we can help you in many ways. There was some discussion earlier about finding MPN specialists. That's one thing we're happy to help you find. We provide disease education with you over the phone, specific resources, and we're just there as a sounding board as well, or just to listen and to help you find your way. We also have nurses who perform free clinical trial searches, and that happens within 24 to 48 hours, and then you're given those results to share with your doctor. We also have a free registered dietitian who provides consultations over the phone, and she's lovely. She's been in the field for many years, and she extends her services to not only blood cancers, but also other cancers as well. And then we also have a lot of ways for patients to connect either one-on-one over the phone or online through our online community where you can post questions, encouragement, and it's a nice way to meet others. We have online chats. And then we also have a nice caregiver package, which just to keep you organized. So it's a binder and it's got calendars, pill box, lots of items that are needed. And then finally, we have a partnership with Subaru going on. So we're giving out some cozy blankets to patients and caregivers. So I'll stop there. And again, encourage you to give us a call. We'd love to meet you. And thank you so much again for the opportunity today.
Thank you very much. I just think it's important to note that some of our partners do things very differently or have other resources available to them that we cannot provide. But we always try to direct our patients to those places. And we really appreciate you being with us today, Amy.
Thank you, Amy.
Thank you. Okay, so we will move along. And our first industry partner that is with us today from Insight, who has supported us for many, many years. And again, we could not do the work that we do without the support of our industry partners. So thank you very much. And with us today is Frances Parisi. And Frances is an oncology clinical nurse educator. Frances?
That's right. Thank you, Anne. I'm so pleased to be here today to represent Insight. And I'd like to thank you, Anne, and the team at MPN Advocacy and Education International for giving me a few moments to speak about our company and its commitment to patients. I'm grateful to have the opportunity also to participate in today's meeting and meet so many people who are impacted by the diseases that our company is focused on. We work and study these diseases on a daily basis, but value these moments where we get to hear your voices and your questions as well. What's important to you and how we as a company can help to be a part of a community of support. Insight Corporation is a Wilmington, Delaware-based biopharmaceutical company committed to making a difference in the lives of patients through scientific discovery. Rigorous science is at the core of everything we do to discover, develop, and deliver novel medicines that will meet the serious medical needs in oncology and other diseases. One of our most important commitments is to help ensure that appropriate patients may have access to the medicines they need. For this reason, we developed a patient support program called Insight Cares to help these patients and healthcare providers access their prescribed medication. Information for patient access can be found at www.insightcares.com. We are currently enrolling eligible patients in clinical trials for MPNs. And if you're interested, please contact your healthcare provider. Detailed information about our clinical trials can also be found at www.insightclinicaltrials.com. We strive to enhance support in the patient community and to integrate the authentic patient voice throughout our initiatives. Partnerships like this one we have with MPN Advocacy and Education International have been key in helping our understanding of the unmet patient and caregiver needs, including raising disease awareness and providing educational information to the community. We host a website called Voices of MPN, voicesofmpn.com, where we, the oncology clinical nurse educators, provide access to MPN information, patient stories, and information for the MPN community events, patient meetings, podcasts, and symptom tracker tools. We created a program called MPN Heroes to publicly recognize individuals who've excelled in caring for a patient or patients with an MPN, or who have advanced the science in MPNs to increase awareness and support in the MPN community. Heroes will take place virtually this year on Wednesday, December 8th at 6 p.m. Eastern Time. Our keynote speaker this year will be LeVar Burton. Cure, you've heard of Cure, is hosting this event. So at Insight, we believe that industry and patient groups can find common ground to develop collaborative partnerships, resulting in meaningful activities. And programs like this allow Insight to use our resources to help improve the lives of individuals most impacted by the diseases in which we work. And we thank you.
Thank you very much. I really appreciate that. And we'll probably see you in another month or so at ASH and see who those heroes are. Thank you very much. So we will move on to CTI Biopharma and Beena Patel, who is the medical affairs consultant. Hello, Beena. Thank you for joining us.
Thank you, Anne. I'm going to share my screen first. Can you see that?
Yes, I can.
Okay. Let me just move it a little bit. Okay, so thank you. My name is Beena and I am a medical science liaison at CTI Biopharma. I want to start by first saying thank you to Anne, Mallory, and the entire MPN Advocacy and Education International team for today's session and for bringing patients, providers, and industry together for an empowering conversation around patient education for those who are diagnosed with MPNs, and also for providing this opportunity to tell you about our work at CTI. We are developing pacritinib, a JAK2 IRAK1 inhibitor for patients living with myelofibrosis and experiencing low blood counts. Please note that pacritinib is investigational and safety and efficacy have not been established. The FDA accepted our new drug application for pacritinib in patients with myelofibrosis, including patients with severe thrombocytopenia or platelet count of less than 50,000, which highlights this unmet medical need for patients who have myelofibrosis in this particular area. The FDA action date, or otherwise known as PDUFA date, is scheduled for November 30th. And to give you a bit of a background, pacritinib has already been studied in over 1,200 patients, including the completed phase 3 PERSIST studies in patients with myelofibrosis. And currently we are enrolling in our pivotal phase 3 Pacifica study of pacritinib versus physician's choice therapy. Pacifica is enrolling patients with myelofibrosis and platelet counts less than 50,000. And the study is open to patients who either have had no prior exposure to JAK inhibitors or who have had a limited prior exposure. The study enrolls patients who have splenomegaly and symptoms related to myelofibrosis, and patients are randomized 2-to-1 to pacritinib versus physician's choice therapy. And this can include ruxolitinib, danazol, hydroxyurea, and corticosteroids. Enrollment is now underway both in the US and worldwide, and you can find more information about this trial at clinicaltrials.gov. I'm also excited to share with you the launch of InsightMF.com, which is a valuable resource that features insights from top myelofibrosis experts on the disease state of myelofibrosis, and more importantly, sheds light on the impact that cytopenic MF has on patients who are living with it. The resource aims to bring together patients, caregivers, and providers to better understand myelofibrosis broadly and find new paths forward in managing this challenging disease. CTI remains excited about our partnership with MPN Advocacy and Education International, and we continue to support rigorous science and data that will bring much needed therapies to patients living with myelofibrosis with the goal of improving symptoms, spleen response, and providing hematologic stability. Thank you for your time.
Thank you so very much, Bina. That was great. And we look forward to seeing you as well at ASH. And we thank CTI for their support over the years. Thank you.
Thank you.
And now we'll move on to AbbVie and Brian Murray, who's a PharmD Oncology Medical Affairs person at AbbVie, who is one of our partners and a great supporter of our programs. Thank you so much, Brian.
Of course, thanks for having me, Anne. Thanks to everyone for being here. In the interest of time, I'm going to refrain from showing any slides, but I will give some verbal updates on AbbVie's activities in myelofibrosis. So AbbVie is evaluating the safety and efficacy of navitoclax combined with ruxolitinib in 2 different phase 3 studies in myelofibrosis. Just a brief background, navitoclax is an agent that inhibits BCL-XL, which is a pro-survival protein. Cancers will often hijack pathways to overproduce this protein to keep themselves alive. And we've shown from some preclinical data as well as some phase 2 data that navitoclax and ruxolitinib can work particularly well together against myelofibrosis. And we've seen some promising efficacy signals in our phase 2 study. On the basis of that, we initiated 2 phase 3 studies last year, and we are actively seeking patients. And I'll describe those now. So our first phase 3 study is called Transform-1. And this is for primary and secondary myelofibrosis patients who are JAK inhibitor naive, so they've not received ruxolitinib, but their treating physician has decided that it's time to start treatment, and then they'd be randomized in 1-1 fashion between navitoclax and ruxolitinib in one treatment arm, and then ruxolitinib and placebo in a second treatment arm. And so this would be patients who are deemed intermediate 2 or high risk by the DIPS plus scoring system. We're actively seeking patients for this trial, and there are about 30 plus sites in the US. Our second phase 3 study is Transform-2. Unlike Transform-1, Transform-2 is also for myelofibrosis patients, but this time they have to have progressed on ruxolitinib. And we're seeking 300 plus patients for this trial, again, evaluating the same combination, navitoclax and ruxolitinib, compared to best available therapy, which can include ruxolitinib, fedratinib, danazol, interferon, hydroxyurea. It's really physician's choice. So again, patients can only have received ruxolitinib. They can't have received more than 1 JAK inhibitor. So if you'd received ruxolitinib and then you progressed and received fedratinib, you wouldn't be eligible for that trial. You can find more information on both trials at myelofibrosisresearch.com. It's a great website. It'll show you the locations of the current studies in the US, and you can also complete an eligibility questionnaire to determine if you might be eligible to participate in the study. But of course, if you want to speak to your doctor to determine if a trial is right for you. And also note that navitoclax is an investigational agent, so it's not FDA approved in myelofibrosis or any other heme malignancy. Once again, myelofibrosisresearch.com for more information. And I'll stop there and transition to the next speaker. So thanks, Anne, again for having me. Always great to be here and speak at these events. So thank you.
Yes, Brian, thank you so much. I hope to see you soon. And moving right along, we'll talk with Pharmacentia and Denise McNeil, who's a PharmD medical science liaison. Hello, and how are you?
I'm good, Anne. How are you today?
I'm good. Thanks for joining us.
Thank you so much, Anne, for the opportunity to be here today. And on behalf of Pharmacentia, I'm actually going to continue on the announcement train that Anne started earlier at the beginning of our webinar. And I'm very pleased to continue to announce that on November 12th, just this past Friday, the FDA approved ropeg interferon alpha 2B under the trade name Besremi for the treatment of polycythemia vera in adults. We are incredibly proud to lead this critical next step in advancing care. This milestone is such a significant achievement for patients with PV and their families who are impacted by this rare blood cancer. Ropeg interferon is an innovative monopegylated long-acting interferon, which exhibits its cellular effects in polycythemia vera in the bone marrow. Ropeg interferon was approved with a boxed warning for risk of serious disorders, including aggravation of neuropsychiatric, autoimmune, ischemic, and infection disorders. Pharma Essentia is preparing to make ROPEG available in the coming weeks in the United States. The US FDA approval was based on safety from the PEG and VERA and PROUD continuation PV studies and efficacy data from the PEG and VERA clinical study program. The study showed that after 7.5 years of treatment with ROPEG, 61% of patients with PV experienced a complete hematological response. And importantly, 80% of patients achieved a hematological response on ROPEG interferon based on lab parameters only, looking at controlled hematocrit, platelet, and white blood cell count. We're very happy to be able to provide an additional option to patients with MPNs, and we feel like this is just the start. Now having ROPEG interferon approved for patients with PV, we also have ROPEG interferon currently being looked at in a phase 3 trial in ET called the SURPASS ET study. You can visit surpasset.com for more information. And especially as we continue to learn more about disease progression, as we learn more about treating patients earlier, as both Dr. Stein and Dr. Resar mentioned, in ways we see that we can make a positive impact in patients' lives. So thank you, Anne, because your partnership is truly giving us this opportunity, and it continues to inspire us. So thank you very much.
Well, thank you very much. And Pharma Essentia has been a great partner, and we're very excited. Thank you. Mm-hmm. And so now we'll hear from Kartos, and Andrea Blank is the VP of Medical Affairs. And Andrea, how are you?
I'm well, thanks, Anne. Thanks again for having us. And thank you also for hosting yet another great event. It's greatly appreciated. So as Anne mentioned, my name is Andrea Blank, and I'm from Kartos, which is a privately held clinical stage company based outside of San Francisco. And Kartos is currently working to study a drug called navtemadlin, or KRT-232, which is a potentially best-in-class MDM2 inhibitor, and it's being studied in several blood cancers and also solid tumors. So what I wanted to focus on today was talking about a few of the trials that we have in myelofibrosis as well as PV. And that includes in the frontline setting, so when a patient is initially starting treatment, as well as patients that have received a JAK inhibitor and have not had optimal response or have relapsed after receiving a JAK inhibitor. Variety of clinical trials are available from Kartos as a sponsor at academic research centers. And so with that in mind, I would suggest that everyone, if you're interested, go to our website to learn more about Kartos and also our clinical trials. The website for Kartos is www.kartosthera.com. Additionally, I'd love to put a little bit of light to one of our phase 3 clinical trials. This trial is called Boreas, and it's specifically for patients who are relapse refractory to JAK inhibitors. So patients who have received a JAK inhibitor have had a good response to it, and now we're starting to see that response fade. Specific to this trial, it's in multiple states in the US as well as multiple countries worldwide. And if there's any interest to learn more about this phase 3 clinical trial, you can go to a website, www.boreas, BOREAS-trial, TRIAL.com to learn more. And with that, Anne, I'll hand back to you. Thank you again for hosting yet another.
Thank you very much. Interesting things are happening in this MPM world, that's for sure. Thank you so much, and we appreciate Kartos' support. Moving right along, we'll go to our friend at Constellation, Shanyi Lau, who is the Field Medical Director. Shanyi.
Hello again, Anne. Very nice to see you again. Thank you for the opportunity, and also want to thank the patients here, also the panelists, for a great conversation yet again. My name is Shanyi Liao, Field Medical Director at Constellation Pharmaceuticals Medical Affairs. For those that of you who don't know us, we are a Massachusetts-based biotech company with over 12 years of discovery and development history focused on epigenetics and cancer biology. Our drug candidates were all developed internally and are products of our expertise in gene targeting for diseases where gene regulation and control matters. As of July of 15 this year, Constellation Pharmaceutical is now a MorphoSys company, and we are committed to developing breakthrough therapies that brings hope to patients. The lead compound generated at Constellation is an investigational BET inhibitor, pelabresib, also goes by the name of CPI-0610, that we are developing as a potential treatment of myelofibrosis. Pelabresib is a novel orally administered small molecule designed to selectively inhibit the function of BET proteins to decrease the expression of abnormally expressed genes in cancer. Please note that pelabresib is investigational new agent and has not yet approved by any regulatory agency. Constellation is currently conducting a phase 2 clinical trial of pelabresib in myelofibrosis and ET, and a larger phase 3 trial called MANIFEST-2 has initiated for myelofibrosis. MANIFEST-2 is a randomized double-blinded study in phase 3 study in adult patients with myelofibrosis who have not been previously treated with a JAK inhibitor. The purpose of this study is to evaluate efficacy and safety of pelabresib plus ruxolitinib compared with ruxolitinib alone. For more information, you can find both MANIFEST and MANIFEST-2 on clinicaltrial.gov or our website at constellationpharma.com. We all recognize that we need new therapies for myelofibrosis patients that addresses the areas of unmet need, and we are working hard to develop such a therapy. At Constellation, our interest and commitment to patients and caregivers extends across the MPN community, as we have additional plans for pelabresib and early stage programs that may have utility in MF and other MPNs in the future. And a final thank you, Anne, and to the MPN AEI for such a great opportunity.
I love that you say MPN, AEI.
I always triple over.
That's cumbersome, right? But thank you so much for your update. I appreciate it. And now we'll hear from Sierra, and Lauren Musto is the Senior Director of Corporate Communications. You've seen Lauren before if you've been with us. Hi, Lauren. Thank you for joining us.
Hello, Anne. Thank you for having us on today. We so appreciate your time and to speak with all of the patients joining us. So, as Anne mentioned, my name is Lauren Musto. I lead corporate communications and patient advocacy at Sierra Oncology. So if you're not familiar with us, Sierra is a late-stage biopharmaceutical company, and we're on a mission to deliver targeted therapies that treat rare forms of cancer, which does include myelofibrosis. Our main focus right now is the development of momelotinib, which is an investigational agent for the treatment of MF. Momelotinib is an inhibitor of 3 key signaling pathways that contribute to those major manifestations of the disease. By inhibiting ACVR1 as well as JAK1 and JAK2, we believe that momelotinib has the potential to improve anemia of myelofibrosis while also improving constitutional symptoms and splenomegaly. We're currently awaiting top-line results for our phase 3 momentum study, which we expect to have by February of next year. The momentum study enrolled 195 of a planned 180 patients who had previously received treatment with a JAK inhibitor and who were symptomatic and anemic. The trial will assess the impact of momelotinib on symptoms, splenomegaly, anemia, and the need for blood transfusions. The primary endpoint is total symptom score response rate at week 24, and secondary endpoints are transfusion independence rate and spleen response rate also at week 24. Assuming the primary endpoint is met, we plan to file with a new drug application with the FDA in the second quarter of next year. Excitingly, in August, we announced that we had in-licensed a novel BRD4 BET inhibitor to expand our pipeline. So SRA 515, which was previously known as AZD 5153, is a differentiated BET inhibitor through its high potency, selectivity, and bivalent binding, which may offer more complete target inhibition relative to other monovalent binders. Now, we believe that momelotinib could be the cornerstone JAK inhibitor for combination use. Unlike other approved JAK inhibitors, momelotinib is not myelosuppressive. Therefore, we believe the combination of momelotinib and SRA 515 may provide improved efficacy and safety over other JAK inhibitor, BET inhibitor combinations. Our plan is to initiate a phase 2 trial examining that momelotinib 515 combination in the first half of 2022 for the treatment of myelofibrosis, and we look forward to sharing more details about that planned study as we get closer to trial initiation. So in closing, Anne, we'd just like to thank you again for inviting us on today, and are so grateful for all the work you're doing on behalf of the MF community as well as the broader MPN community, and we look forward to working with you in the future. Thank you so much, everyone, for your time.
Thank you very much, and for your support, for Sierra Oncology support, and we will see you possibly at ASH.
We look forward to it.
Thank you. And now we'll move on to Imago Biosciences and Wanjun Hong, who is a physician and chief medical officer there. And hello, how are you? I saw you briefly in New York, not long enough. I'm anxious to hear what you have to share with us.
Thank you, Anne, for the time. I know we're kind of short on time, or we're already over time, so I'll just keep this really brief. Hi, my name is Wanjun Hong, and I'm the CMO of Imago Biosciences. Imago is a public company founded in 2012 and is based in South San Francisco. And the focus of our company is to develop treatments for MPNs. Our approach is to target genes that regulate blood formation, specifically those that are regulated by epigenetic enzymes such as LSD1 or lysine-specific demethylase 1. And this is an enzyme that regulates maturation of blood cells. Our leading molecule is bomedemstat, or was previously known as IMG 7289. And this is an oral LSD1 inhibitor that's taken once a day. So we have currently 2 ongoing sponsored studies, one in MF, which has already completed enrollment. And we expect we'll be presenting some updated results at the upcoming ASH meeting, as well as an ongoing study in ET, which is still open for enrollment. And also we'll be presenting some updated results at ASH. So, we just basically have those 2 ongoing studies, and we hope to initiate some combination studies with bomedemstat and ruxolitinib as an investigator-initiated trial. So thank you for the time, and I think I'll just hand it back to Anne. This is quick.
Thank you very much. It's just remarkable how much is happening, and Imago's been a great partner for a long time, and we're really proud of all of you. And thank you again, Wanjun. We really appreciate it. And so in closing today, I would just like to say thanks to all of our speakers, all of our presenters today, and our physicians, Dr. Resar and Dr. Stein. And to all of you, we will continue hosting these programs throughout the rest of next year. This was our last one this year because we are about to prepare to go to ASH. We are going in person with lots of safety efforts in place, and we will be back in, we'll do a follow-up after ASH, and then we will be back in January, and we do plan to host some events in person in January, 3 at this time, and we will let you know where those are and who will be speaking at those programs. But as I said, we will continue to do the online programs because it's just been so beneficial to the MPN community. And we truly appreciate you joining us and all of your support. Thank you very much, and be safe.